Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
This program is presented by Medscape Education Global.
Hello and welcome to this Medscape program titled Evolving Strategies for Metastatic Breast Cancer, a deep dive into recent progress. My name is Fatima Cardoso. I'm a medical oncologist and the director of the breast unit at the Champalimaud Clinical Center in Lisbon, Portugal. And I'm joined today by my colleagues and friends, Kamal Javeri. Kamal?
So I'm a breast medical oncologist from Memorial Sloan Kettering Cancer Center in New York, and it's an absolute pleasure to be here with both of you today.
Thank you. And Nicola Fusco. Nicola, please.
Thank you, Fatima and Kamal. It's a pleasure to be here. My name is Nicola Fusco. I'm a pathologist. I'm the head of the Division of Pathology at the European Institute of Oncology in Milan and professor of pathology at the University of Milan.
Thank you so much to both of you for being here. And in this program, we are going to discuss the latest data on the management of metastatic breast cancer, particularly in the context of what was presented at the latest ESMO conference 2024. So we are going to start with HER2-positive metastatic breast cancer, and I'm going to briefly discuss or highlight to you the major findings of two studies that were presented regarding this subtype. So the first one, and possibly the one that brought the best news for metastatic breast cancer at this conference, was Destiny Breast 12, that look into the use of trastuzumab deruxtecan in patients with HER2-positive metastatic breast cancer and brain metastases. So in this trial, that was a phase 3b4, there were two, let's call them two cohorts, one with patients without brain metastases at baseline and one with patients with brain metastases. That is really the most interesting one for now, and it had 263 patients. What is important to know about the patient population that I would like to highlight is that these patients have received one or two prior lines of therapy in the metastatic setting and were tucatinib naive. And this will be important interpreting the results. Also important, and we will briefly discuss this, unfortunately, leptomeningeal disease was again excluded from these trials. The primary endpoint, in my perspective, also unfortunately, was PFS, but at least it had an important endpoint of PFS in the brain. And what it showed was that both for what they call stable brain metastases and active brain metastases, the active being brain metastases that had not been treated or were treated but were progressing, you had a 12-month PFS of about 61%, very similar between stable and active brain metastases, with an estimated median PFS of 17 months. Also, then interesting, the response in the brain was about 71% overall. In here, higher in stable brain metastases than in active brain metastases. In terms of toxicity, there was nothing new regarding previous reports on this drug, always knowing that there is a possibility of ILD pneumonitis, and this can be potentially fatal. And the OS, we only have data for 12 months, but and of course this is not a randomized trial. So what we can say is 12 months overall survival was around 90%, both for patients with and without brain metastases. So this trial has brought news of additional data reinforcing that trastuzumab deruxtecan has some activity in brain metastasis and can be an option of treatment. The second trial for this subtype was an update on the DETECT-5 trial, and this trial looked into a de-escalation strategy in what we sometimes call triple positive metastatic breast cancer. So what the investigators wanted to see is if we could omit chemotherapy and then look into the combination of endocrine therapy and dual blockade. So the comparison was induction with chemotherapy, dual blockade, and then maintenance endocrine therapy, or upfront endocrine therapy and dual blockade. Throughout the trial, an amendment was made to add ribociclib to endocrine therapy, both in the maintenance arm and the upfront arm. And although this is a relatively small trial, because only 270 patients were included, and this was not just in first line, was first to third line therapy, what the results show is that there was no important difference of efficacy between the arm that received chemotherapy and the arm that did not receive chemotherapy, and obviously toxicity was different. For the results of ribociclib, taking into account that this was not randomized, but it looked that, or it points and raises the hypothesis that also for this subtype, the addition of a CDK4/6 inhibitor to maintenance endocrine therapy or upfront can lead to improved outcomes. And this is being tested in randomized trials such as the PATINA trial. So, Kamal, what do you think are the clinical implications of these two studies?
Yeah, no, I think, thank you for summarizing, first of all, these important data sets that were presented. Now, essentially, when we think about antibody drug conjugates, we think about them as large molecules, not as small TKIs. And a big question that comes up is, will it actually penetrate the blood-brain barrier? Will we see anything in the brain in terms of responses? But we had begun to see that with TDM1 in data sets. We had begun to see that with trastuzumab deruxtecan across many smaller data sets as well, including the DEBRA trial, the ROSETTE-BM trial, the Tuxedo trial. These were small data sets that were already saying that maybe there is activity. Pooled analyses from the DESTINY trials in the metastatic HER2-positive setting had also given us a sense that, at least for patients with stable brain metastases, we do see activity. But what was nice about the DESTINY-Breast12 study, that despite not being a randomized study, despite not having a randomized arm for patients with brain metastases, I think it's one of the largest data sets with about 250 patients, as you said, looking at the activity in the brain, including in patients with active brain metastases, and seeing that it works there as well. So to me, when I was thinking about what would I offer a patient in the second-line metastatic setting with HER2-positive breast cancer, I was always thinking about, okay, what's happening with systemic progression? What's happening intracranially? And is there only intracranial active brain metastases with controlled systemic disease where I would have offered tucatinib? I certainly could still do that, but I think the DESTINY-Breast12 gives me more confidence about patients who have progression both extracranially and intracranially, including with patients with active brain metastases, where I would now consider TDXD. So I think, to me, that has made me feel very comfortable about utilizing this very active agent beyond how we were using it in the second-line setting.
Thank you. I think I would make just an additional comment, because it was a comment raised in the discussion at ESMO. So, of course, when we have active brain metastases, we have to make a difference between active brain metastases, because there has been a progression and no additional radiation was given, or the first presentation of brain metastases and in limited number, limited size that can be treated with radiosurgery, right? So radiation therapy. And I think there was this discussion, oh, we don't need radiation anymore. But it's important that everybody is aware that the response of radiosurgery in the brain is very effective and less toxic. And so we now have two options, particularly for me, particularly important if my option is only whole brain radiation, then I can shy away from that and continue the systemic therapy.
Yeah, no, I think it's such an excellent point. And I think that's an excellent point for us to remind ourselves for any treatment option that we currently have available, even in the HER2 CLIMB trial that led to the approval of tucatinib, capecitabine, and trastuzumab. Even there, these are tumors that are less than 2 centimeters where you don't think these patients require immediate local intervention with either surgery or radiation. Only then will you actually think about systemic options that can control that. This would not be a patient who presents with headache or has edema or has a 4-centimeter tumor where you're thinking about local interventions first anyway. But certainly for those patients where you're trying to avoid any other interventions and they don't require any local interventions, we at least now have multiple data sets suggesting that there are options if you're worried about systemic disease or worried about brain disease, that perhaps systemic therapy can have an impact on both these scenarios. So I think excellent point to discuss.
Thank you. Nicola, don't go away. We haven't forgotten about you, and we're going to involve you very deeply in the next set of data. So let's move on to the other subtype, which is ER positive, HER2 negative, and HER2 low metastatic breast cancer. And I'll ask Kamal if you could lead us through the trials that were presented for this subtype.
Yeah, absolutely. Thank you. So I think when we think about HR positive, HER2 negative at ESMO, one of the trials that I'd like to highlight will be the phase 2 Abigail trial. Now, the Abigail trial is not unique in terms of asking a question. The question is something that we have asked before. For example, the Right Choice trial did ask the same question of, do all patients require chemotherapy, especially if we're thinking they have aggressive disease or visceral disease that might be bothersome or considered aggressive? And are they appropriate for upfront CDK4/6 inhibitor, which is otherwise our therapy of choice for majority, if not all our patients in the first-line metastatic setting? So similar to what was done with, say, Right Choice as a question with ribociclib, Abigail was designed to evaluate if abemaciclib plus endocrine therapy, when compared to paclitaxel in this case, induction, and then followed by abemaciclib and endocrine therapy, would be an effective way of treating a patient who might have some aggressive behavior. So in this phase 2 trial, approximately 160 patients, these are patients who've not had any prior therapy for advanced breast cancer. They were required to have measurable disease, and they could have been AI sensitive or could have been resistant to an aromatase inhibitor, but were required to have at least one aggressive factor. And then these patients would then get randomized to either an induction 12-week regimen with paclitaxel or abemaciclib with either letrozole or fulvestrant. And after the 12 weeks, patients would then continue with the CDK4/6, in this case, abemaciclib with endocrine therapy, for a primary endpoint of looking at overall response rate by blinded independent central review. And what they found was that Abigail met its primary endpoint, that it met its endpoint for the 12-week overall response rate, which was approximately 60% in the abemaciclib plus endocrine therapy arm compared to 40% in the paclitaxel arm. And the toxicity profile observed after 12 weeks was as expected according to each treatment strategy. So no surprises there. Right now, what we're looking forward to is evaluating long-term efficacy, including progression-free survival, which we currently don't have. We have the primary endpoint results. It is in line with what we have been thinking about with CDK4/6. We look forward to more data from that study.
Yes, so thank you. Perhaps I just make a small comment on this trial. My first thought when this trial was presented was, why are we still asking this question? So aren't we, don't we have sufficient data already to know that this subtype responds much better to endocrine-based manipulation than to chemotherapy?
I completely agree. I think, we actually had initial data from the Korean group, the Pearl trial. These were patients who had had prior tamoxifen, and then in the second line, got the CDK4/6 with exemestane compared to capecitabine, and clearly it was superior in that strategy. Then came right choice, where we saw even patients who were supposedly with visceral crisis, and they had given those definitions of how they define visceral crisis. And even in that aggressive patient population, comparing to a doublet chemotherapy regimen, we showed that, you know, a CDK4/6 was appropriate. So you're absolutely right. Do we really need to keep asking this question? Are we not convinced that that's the case? But now we have all three CDK4/6 inhibitors, all three different ways of doing it. And certainly it seems like it's a very appropriate strategy.
So let's now move to the discussion about HER2-low and ultra-low. So at ASCO this year, we had previously seen the results of DESTINY-Breast06. And very briefly, this trial had two major differences for example, DESTINY-Breast04. In this trial, besides including HER2-low, there were also a small subset of HER2 ultra-low, and we'll discuss what that is in just a brief moment. And just a note that these HER2 ultra-low tumors were only 153. The other difference for the DESTINY-Breast04 was the line of treatment. In DESTINY-Breast06, patients were chemotherapy naive for the metastatic setting, so no chemotherapy allowed, and they had received at more or less 2 lines of endocrine therapy, counting 2 lines in the metastatic, or depending on the time of progression, counting also the adjuvant endocrine therapy. But let's say that overall, this is a less treated population than DESTINY-Breast04. The primary endpoint was PFS in the HER2-low. So the analysis of ultra-low is secondary, and it's based on 153 patients, as I said, had comparison, trastuzumab deruxtecan, and physician's choice of monochemotherapy. And what was shown is that we see a difference in PFS in the HER2-low of about 5 months. So similar to what we saw in DESTINY-Breast04. When we add the HER2-low and ultra-low population, we see a very similar difference, almost the same results in the group of low and ultra-low than we see in the HER2-low population. So these were discussed at ASCO. Now, a lot of discussion came after that, particularly regarding how reliable is it in clinical practice in our pathology labs, this determination of HER2-low and HER2 ultra-low. Nicola, can you guide us through what was presented and discussed at ESMO regarding this?
Yes, absolutely, Fatima, and thank you for summarizing the results of the DESTINY-Breast06. And indeed, the reproducibility of the HER2 testing, particularly in the lower spectrum of expression, is now gaining momentum. And at ESMO, the Professor Viale demonstrated how crucial is the reassessment of HER2 status, particularly for HER2 score 0. And indeed, in the study presented at ESMO, a clinical validation of the local and central HER2 scoring of the DESTINY-Breast06 was performed. And in particular, the HER2 scores were centrally determined using the Ventana 4B5 assay, which is a monoclonal rabbit primary antibody, and using also a reflex in situ hybridization assay if in case of 2+ by immunohistochemistry. And the samples from the patients with metastatic disease were tested. And therefore, the concordance between the local and the central HER2 score was assessed by the overall percentage of agreement, and also a subgroup analysis with progression-free survival were performed for sample characteristics. And in summary, the results revealed that the central and local HER2 test results are a relatively significant number of discordance, particularly in the score 0, in the score 0 spectrum, and we know that the score 0 encompass also a subset of ultra-low cases. That means that they have still a barely perceptible faint positivity for HER2 in the membrane of the cells, and but in less than 10% of the tumor cells. And the central HER2 immunohistochemical score in this study was consistent across all the key variables of the population that were locally scored as HER2 negative. But in my opinion, the most interesting results were related to the concordance between central and local results, where the overall agreement for HER2 low was 77.8%, and 64% of cases with membrane staining were detected also locally. So, in my opinion, this study highlights some key points that we can bring in our clinical practice. First of all, that patients with hormone receptor positive, HER2 low or ultra low metastatic breast cancer have clinically meaningful benefit from trastuzumab deruxtecan. So even a low, ultra low expression of the biomarker is clinically meaningful. And another point is that the overall percentage of agreement is quite high, but still not enough, because it's 78%. And in the conclusion that we can draw in the clinical practice is that all patients with hormone receptor positive metastatic breast cancer that were previously scored as HER2 immunohistochemistry 0 should be reassessed to determine if they might be eligible for trastuzumab deruxtecan, and if they have an ultra low expression. The point here is that is the clinical rationale that increase the sensitivity and the predictivity of HER2 testing.
So let me ask you a provocative question. Don't you think that now pathologists are going to be tortured not to say that it's score 0?
Yeah, that's a good point, Fatima. And our job is to be tortured, so oncologists are very much welcome to torture us for this type of analysis. And indeed, I believe that, and we still do in the clinical practice, all the HER2 score 0 should be reassessed according to the ASCO CAP and the ESMO 2023 recommendation that basically endorsed the previous guidelines and recommendation, but with a specific focus on the clinical rationale that may change the results in the score 0.
I think that I would just add the fact that other studies have shown that this biomarker is quite unstable in the course of the disease. And so more than testing the same sample again, I would probably wait and test again in the next line and see if the biomarker has changed. I will ask now Kamal to continue with the studies that were presented with trastuzumab deruxtecan. If you could guide us through the safety and PROs, please.
Yeah, absolutely. Thank you so much, Nicola. Be careful what you wish for about getting calls from oncologists. That's all I would say. But thank you for being available for us, because we will surely call you. And so I'll continue about, certainly it's important to, provide efficacious drugs to our patients. Also important to not forget the fact that safety and quality of life are a very important, finding that we want to focus on for our patients in clinic. And so it was nice to look at even the PRO data, the patient-reported outcome data from trastuzumab deruxtecan in HER2 low and HER2 ultra low tumors. Specifically, they looked at the EORTC questionnaires, the C30 quality of life questionnaires, and the BR45 questionnaires, which are breast cancer specific questionnaires as well. And just to summarize what we learned from that is that duration of treatment was approximately twice as long with trastuzumab deruxtecan compared to physician choice chemotherapy. And importantly, quality of life was maintained during treatment with trastuzumab deruxtecan. The time to deterioration was in fact delayed in physical and role functioning and pain compared to physician choice chemotherapy. So really, really important for our patients to be reassured or at least communicated with that, yes, this drug works and yes, the quality of life is maintained and there is time to deterioration delay for pain and other physical and role functioning. The GI symptoms that were reported by patients receiving trastuzumab deruxtecan in this study did not really appear to be detrimental to the overall preservation of quality of life and were in fact consistent with the clinician-reported safety data as well. So further investigation of looking at antiemetic prophylaxis for the GI adverse events and associated quality of life in patients receiving trastuzumab deruxtecan is warranted. In fact, I'd like to share that the triple antiemetic regimen that we use has really been a big game changer for managing nausea for my patients in clinic. And so certainly I use that. And in many of the patients, I also offer them olanzapine as needed. And that has really dramatically declined the prevalence and severity of nausea in my experience in clinic. And would be curious to see, Fatima, if you have had that same experience as well. But that was something that I thought was very neat to learn from this poster and clinical experience so far.
Absolutely, I think it is a must that we do prophylaxis, primary prophylaxis.
Fantastic. Yeah, we do the same, and it's made such a big difference. Now, certainly nausea is the most common side effect that we face with trastuzumab deruxtecan, but adverse event of special interest that we really focus on and are very vigilant about and really want to be very communicative about is interstitial lung disease with trastuzumab deruxtecan. And so this was a very nice French effort looking at a real-world data set in over 600 patients who were treated with trastuzumab deruxtecan from 2019 to 2023. So what they had done was they had collected the clinical and the radiological data from electronic medical records for these 600 patients. And these could have been patients who could have had breast cancer, lung cancer, colorectal cancers, gastroesophageal junction cancers, and could have been treated with doses of trastuzumab deruxtecan anywhere between 4.4 milligrams per kilogram to 6.4 milligrams per kilogram every 3 weeks. And so they collected this data, and among the 600 patients, majority of these patients were females, majority were non-smokers, approximately 75%. Median age was about 60 years. 3/4 of this patient population had already received prior radiation therapy to the chest, and about half had received prior HER2-targeted therapy. And what we learned was from reviewing this data that the incidence of interstitial lung disease in real world in this French cohort was about 11%. So 67 patients out of the 600 had developed ILD, and median time to developing ILD was about 83 days. And these patients had received a median of about 7 cycles of trastuzumab deruxtecan. They had already received a median of 3 prior lines of therapy before they were receiving trastuzumab deruxtecan. And then they also presented very interesting radiological presentations that they saw with ILD presentation and the risk factors, and also the clinical presentations that they noticed. So when it comes to clinical presentation, half the patients had shortness of breath, approximately 40% presented with cough, a very small proportion with fevers. And the most common risk factor, or the strongest risk factor, was prior ILD. So it was not the presence of lung metastases, because majority who developed ILD, the tumor was still controlled. But the strongest risk factor was if a patient has already had ILD from prior therapies. And that was 16 out of the 67 patients. Radiologically, I think there were 4 different kinds of scenarios that they came across. They reported majority had ground glass opacities that we all know about, 87%, and consolidations. Organizing pneumonia was a predominant pattern, 52%, with some atypical void-shaped consolidations that they reported, and 9% had this diffuse alveolar damage that they also saw. And the ILD severity ranged predominantly low grade 1 to 2, and approximately 10% had grade 3 or 4 ILD, fatal ILD approximately 9% of this patient population. And of these 9%, 4 had this diffuse alveolar damage pattern. So I think it was very interesting to learn about what kind of findings were seen when patients had a bad outcome, what was the radiological finding. So we can learn from this and keep a very close eye on that, but not to forget that we really have to be very vigilant about this. We really have to intervene early, hold the drugs, offer them steroids. 60% of this patient population did receive steroids. And then after they received steroids, there were patients who were able to, get improvement with steroids as well. They reported on that as well. So very good study to just remind us of what patients, in the real world experience with ILD and what kind of findings we see.
Thank you. Thank you for excellent summary. I think what I would highlight is the fact that we have to be extremely careful with re-challenging the patients who had ILD, even low-grade ILD. So it's something we knew from trials, but I think we have learned here even more. And the link between this alteration, alveolar alteration, and death is quite clear. So clearly we have to act very quickly when that situation happens. So thank you very much. Let's move to the last subtype, the metastatic triple negative. And I will ask Kamal to discuss just one trial that were presented, and unfortunately not very good news, but it's important to learn from negative trials as well.
Absolutely, absolutely. At least it makes us learn that we don't need to keep pursuing this because we're learning more about this. So the trial that Fatima, you're referring to is the Capitello 290 study, which was a phase 3 trial that was looking at capivasertib, an AKT inhibitor, in combination with paclitaxel versus paclitaxel plus placebo as frontline treatment for locally advanced inoperable or metastatic triple negative breast cancer, and also for those patients who also harbor alterations, whose tumors harbor alterations in PIK3CA, AKT1, or PTEN alterations. So essentially, the trial was a phase 3 trial, which was really encouraged from the phase 2 PAC trial, which was a phase 2 trial in the same patient population. And there we did see that there was a statistically significant improvement in progression-free survival, and also an overall survival gain was seen there as well. And that was better in the altered patient population. So the PI3K, AKT, PTEN had a deeper or better benefit in the phase 2 study. And so the phase 3 study was a registrational, larger study to confirm this. Unfortunately, as you pointed out, whether we looked at the primary endpoint of overall survival in all patients with locally advanced or metastatic, or in those with PIK3CA, AKT, or PTEN, the trial did not meet its pre-specified primary endpoint for that. Overall survival in both of these populations. There was a numerical gain in PFS, but the primary endpoint was not met. So at least we have learned two things. One, I would say that phase 2s are phase 2s, and you do need confirmatory phase 3s for that reason. And two, that while we have interrogated this with ipatasertib and now capivasertib, unfortunately for triple negative breast cancer in the first line, we've not been able to show that there is a benefit with this approach yet.
Thank you. And I think you're definitely right. One of the take-home message is please always confirm what you see in phase 2. But I think the investigators should be commended for using the proper endpoint, because obviously in triple negative survival is very important, and also for looking into the biomarker. And perhaps, Nikolai, you could tell us something about the role of biomarkers for triple negative. And for example, looking into this altered pathway, how difficult is it for pathologists and molecular biologists to do it?
Yeah, that's a great point, and thank you, Kamal, for summarizing this study. Actually, I think that despite the negative results, there's a value for bringing the PI3K pathway into the triple negative spectrum. Yes, the testing for the entire pathway is a challenge because we not only have PI3K and AKT, in which we have somatic mutations, we also have PTEN, that usually in breast cancer is not a target for mutation, but is lost. So the type of testing strategy require of course, NGS approach, but with specific expertise to be able to capture both the mutational spectrum, but also the gene loss and copy numbers.
So I think we have covered the majority of the most important news. There were also other studies that when we were preparing, we also thought they were very interesting. We apologize for the investigators of those studies that we are not able to summarize. I want to thank Kamal and Nicola for this great discussion, and thank you for participating in this activity. Please continue on to answer the questions that will follow and complete the evaluation. Thank you.
This program was presented by Medscape Education Global.